If not, first up will be Karah Greene and Erik Ruiz from the University of South Florida talking about their virtual village project. So Karah, Erik, share if you can and take it away.
Yeah, and I have the pleasure of doing the introductions for all of our speakers. So our first set of speakers are Karah Greene and Erik Ruiz, and Karah is an advanced standing Master of Social Work student at the University of South Florida, and she's set to graduate this December. Congratulations, Karah.
Thank you.
And her research interests include health disparities, childhood trauma, and the cognitive health of vulnerable populations. She's a Tampa site coordinator for the study she is about to present, preparing for a virtual village to assist people aging with HIV during the COVID-19 pandemic. And she is joined by Erik Ruiz. Erik is a first-year PhD student in public health with a focus on community and family health at the University of South Florida. His research interests center the supportive mental health care needs and psychosocial outcomes of Latinx adolescents. He is also a graduate research assistant and project coordinator for a study examining the health literacy and social support needs of Latinx people in the US and abroad during the COVID-19 pandemic. So 2 very impressive students. We're very lucky to have them with us today, and take it away.
Good morning, everyone. Both Karah and I are really excited to be here and present this project for you. Today, we will share with you a new project that will ideally work to reduce adverse mental health outcomes and social isolation experiences for people aging with HIV in the context of the COVID-19 pandemic. Next, please. Our objectives for today's presentation include introducing the research team, providing background and rationale for the project, describing our study aims and methods, presenting our community advisory board members, and finally describing our current progress and expected next steps. Next, please. So our research team is an academic community partnership comprised of researchers from the University of California, Riverside's School of Medicine, the University of South Carolina's Keck School of Medicine, and the University of South Florida's School of Social Work and College of Public Health. Our research team is also led in collaboration with the community-based and community-supported coalition HIV+ Aging Research Project, known as HARP. Next, please. To give context to this project, it is important to know that our understanding of the supportive care needs of people living with HIV is limited. However, data is emerging. Older people living with HIV may face unique challenges related to the normal aging processes. Discrimination and trauma have contributed to significant adverse mental health outcomes within the PLWH community. And finally, social isolation and adverse mental health outcomes have emerged as a priority concern within the community. Next, please. Our rationale for this project is founded in the context that the COVID-19 pandemic may have exacerbated already stressed living conditions for people living with HIV. As a means to better understand this added pressure, principal investigators and co-PIs from our research team conducted a rapid response need assessment. Some of their findings include that over half of people living with HIV experience anxiety, more than 40% reported feeling socially isolated, 1/3 experience financial challenges, including 20% of whom experienced challenges in paying for basic needs, and then almost 30% had missed a dose of their HIV medication. And I'm sorry for the slide, it looks like I got moved a little, but given these preliminary findings, the research team has begun the process for developing a virtual platform to address these issues. Namely, we seek to connect people living with HIV to medical and social services and reduce social isolation by facilitating peer-to-peer connection through convenient modality. Next, please.
So we have 3 study aims. In aim 1, we're going to be holding focus groups and interviews with people living with HIV who are at least 50 years old or older. And they will be in the 3 study sites, which is Palm Springs, California, Los Angeles, California, and Tampa, Florida. And these focus groups and interviews will help us further characterize issues related to depression and isolation and identify the basic needs of older people living with HIV during the COVID pandemic. Then, using the data we collect from the focus groups and interviews, we will conduct conjoint analysis. This will help us work with the CAB to co-develop ideas for what to include in a virtual village with other key stakeholders who are involved in HIV care, including HIV researchers, people living with HIV, and HIV care providers. I'd also like to provide a brief definition of what conjoint analysis means in case you were wondering. It is a type of methodology that's frequently used in marketing research to determine the value that consumers place on certain items, which can influence buyer decision-making and the choices they make. And then after AIMS 1 and 2 and AIM 3, we will be piloting the virtual village platform. And this will be a low-cost platform with a group of people aging with HIV in Palm Springs, California. Next slide, please. Now I'd like to go over our participants. So for the CAB, we have 24 CAB members. In the Community Advisory Board, it is composed of people living with HIV who are at least 50 years old and from the 3 study sites. So we have 8 people from Palm Springs, 8 people from Los Angeles, and 8 people from the Tampa site. In the AIMS 1 and 2, we will be conducting a total of 9 focus groups. That will be 3 focus groups per study site with 6 to 8 people per the focus group. So we'll have a maximum of 72 participants for AIM 1. And then in the second part of AIM 1, which is the individual key informant interviews, we will have 24 maximum interviews that we conduct. So with conjoint analysis, that is going to be with a total of 96 individuals from AIM 1's focus groups and interviews that we will be analyzing their responses and conducting the conjoint analysis. And then for AIM 3, we have piloting the virtual village platform, which is also going to be referred to now as the project name is Positive Connections 50+ or PC 50+. And that will be 24 people in Palm Springs, California. For our CAB, what's great about having our CAB is that they're an integral part of every part of the decision-making process and what we decide to include in the virtual village. And who better to inform us about what people living with HIV may benefit from than the very community we're trying to serve and help reduce their social isolation. And it is a very diverse CAB. They have varying levels of educational attainment, community involvement, the years they've been living with HIV, their sexual orientation, their overall health status, their gender, their race and ethnicity, and their occupation. They meet once a month. So far, we've had 3 meetings. They are all people living with HIV who are at least 50 years old. And ultimately, they will be providing ongoing input throughout the course of our study. Next slide, please. This is just a screenshot. We gained the CAB members' consent to take their photo during our last CAB meeting, which was held on May 5th. And this is only half of our CAB, along with some of our research team members. So as you can see, we have a very diverse group, varying race and ethnicities, and they all bring certain valued experiences that can help us develop this virtual village. Next slide, please. Next, I'd like to cover what we've accomplished so far. So on the left, you'll see a timeline. We started in January, and first we needed to develop our community advisory board. We did this by recruiting 8 people each from all 3 study sites. And after we were able to recruit all of them between January and February, we were able to hold our first CAB meeting in March. And during the March meeting, we were also able to develop AIM 1 focus group and interview questions and start getting CAB feedback on what they think we should be asking our research participants. And then in April, we held our second CAB meeting and we voted on a project name, which was created by one of the fellow CAB members, which is now Positive Connections 50+ or PC 50+, as I originally stated. And then in earlier this month, we held our third meeting. And that is when we officially moved forward with the project name and we finalized our AIM 1 materials, which is now pending institutional review board approval, which will be the focus group survey and the questions we will be asking during AIM 1. Ultimately, with CAB input, we've been able to accomplish 3 major things so far. They helped make our focus group questions more understandable. So for example, instead of asking how have you been coping during the COVID pandemic. Now we're going to be asking participants, what are some enjoyable things you've been doing during the COVID pandemic? They were also able to help us more clearly define the time frame of the COVID pandemic because certain different people might be viewing that as a different type of time frame. So now in our lead-in questions during the focus groups and interview parts, we define the time frame as between March 2020 and present day. They've also been able to help us develop those focus group and interview questions using 4 main themes, which is coping during COVID-19, health issues, isolation, and virtual village ideas. Next slide, please. Now that we know what we've accomplished so far, I'd like to let you guys know what our next steps are. So next, we're going to be developing our project logo to pair with the Positive Connections 50 Plus name. And we're going to start recruiting participants for the AIM-1 focus groups and interviews. The CAB members are going to continue playing a vital role in this study. They're going to help us create and vote on the favorite logo for the project. They're also going to help us network and connect with the community members for identifying potential research participants for AIM-1, and they will be active in our recruitment process. We will also be contacting community stakeholders from all 3 study sites, which it's Palm Springs, California, Los Angeles, and Tampa. And we're going to be contacting them directly with our flyers and calls and in person so we can start recruiting those participants for AIM-1. And we will then recruit all of the participants that we need and facilitate the virtual focus groups and interviews via the Zoom platform. After that, we'll move into AIM-2, utilizing our results and data from AIM-1. And all of that will be used to pilot the virtual village and ultimately, after analyzing the data and how the virtual village hopefully helps reduce social isolation and depressive symptoms among people living with HIV, we can then publish those results and share with the community. Thank you. Is there time to ask any questions? Okay.
Yes, there's time.
Yes, go ahead. So if anyone has any questions, unmute yourself or raise your hand.
Yes, hi, I have a question. So the goal of the project is to, maybe I missed it, to set up a virtual online community so people can talk to each other and communicate, but online, right?
Yes, and so with our CAB and the information we gain from AIM-1 with other people living with HIV, we'll be able to identify what kind of peer support networking might be most beneficial to reduce social isolation, different types of community providers in all 3 study sites that people living with HIV find the most helpful. And then we will be developing a prototype and ultimately piloting that virtual platform in a small amount. It's about 24 people, up to 24 people in Palm Springs, to determine if it's helpful and helps them feel more connected to other people.
Sounds good, thank you.
Thank you.
Any other questions? And as a reminder, if you're asking a question, just briefly introduce yourself. And thank you everyone who introduced yourself in the chat. That's very helpful.
Steve Karpiak here. Do you think that okay, how will you measure if your socialization has been improved?
That's actually a really good question. I know that the initial study, the rapid needs assessment, had been able to measure social isolation. Actually, we have the person who did that study, Dr. Brown, on this call. I don't know that we have an official method to evaluate improved social isolation. I believe we'll just be completing a survey, have the participants who pilot the virtual village complete a survey that will just ask, how have you been feeling? Did you find this beneficial? Do you feel more connected to your peers?
Yeah, and this is Jeff, just to add to that. So to answer your question, no, we haven't selected a particular instrument yet. And if you have any validated instruments that have been used, you know, in this field before that you recommend, we all ears. So any suggestions you have?
I'm glad to discuss this later. Thank you.
Thank you.
Terrific. Anyone else with questions? We're actually ahead of time, so thank you, Karah and Erik, for staying within your time frame. And so we have another 5 minutes for questions if people have them.
I have a question.
Yeah, go ahead, Lonnie.
I'm just reading who is on this call, and it's so impressive. I was wondering if we could receive a list of what we've all written, just so we know who's participating. It's very exciting.
No, that's a good idea. And yeah, we are recording the call, and I will record the chat. So anything that comes up, and that's a good idea to kind of create a list of attendees. And then we'll make sure if you don't want to be included on that list, please let us know for whatever reason. We're happy to honor people's request for privacy. But otherwise, we can share that list with everybody who's on today's
Thank
meeting.
you.
There's a question in the chat from Thomas.
Ah,
Oh, I see. Is there any concern that reopening the economy this summer might influence feelings of isolation? That's a really good point. I think that's something that we will need to consider moving forward, especially since our intervention is really focused on how COVID has impacted people living with HIV and their feelings of social isolation and getting their needs met through the pandemic. So that's definitely something to consider moving forward. And I'm sure our CAB can help us with that.
Thank you. This is Tom. I'm unmuted now. A follow-on question. What types of interventions are you considering? Since this will be a virtual platform, correct?
right.
So that would limit,
Yes.
obviously that will influence the types of interventions or connections, the functions that you consider. What are you considering?
So this is Jeff
That's-
again. Go ahead, Karah, if you.
Oh, I was just going to say the virtual village itself is the intervention. And so with the focus group and interview feedback that we get, that's going to inform what the virtual village looks like. So at this point, we don't really know, but before we get that feedback from the community. Jeff, I didn't know if you would like to clarify
Yeah,
or
so
elaborate on
You're
that.
absolutely right. And then as Tom was suggesting, and I think we intimated what we wrote was that this can serve as a platform for other interventions. Because you have, you know, this audience and especially online ones. So one that we have, we're looking into with investigator colleagues from the RAND Corporation, I think one of them is on the call today, is looking at doing peer-led problem-solving therapy, which has been done in other settings where you train, you know, peers to help kind of in a support group setting, do problem solving with people. And I think it's all peer-led. So we're going to look at that model as one. We haven't been able to get it funded yet, but it's one thing we're considering. And again, if people have ideas about things that you think might work in a virtual setting like this, we're all ears, because once the platform is up there,
Definitely.
you know, it not only benefits the people, but it helps us to be able to study what works and what doesn't, and how feasible it is.
Great. I would think that perhaps things like system navigation or service navigation, helping connect people to helpful resources, maybe something that could be considered,
Right.
various things. So great to hear that you're open to ideas, and perhaps I'll suggest a few. Thank you.
That's great. Thank you so much.
Terrific. Anybody else? Time for one last question if anyone. If not, we'll move ahead. Oh, Annie.
All right, so our next speaker will also be speaking on a virtual village, and this is a project that started before the one that we just heard about. So I think it'll be interesting to kind of see sort of the product of a virtual village. And our speaker is Elisa Barnett. Elisa is the Senior Services Program Manager at the San Diego LGBT Community Center. She holds a master's in nonprofit leadership and management from the University of San Diego and has been working in the San Diego nonprofit sector for the last 10 years. So Elisa, if you can share your screen and take it away.
Hi, thank you for having me here. I'm Elisa Barnett. My pronouns are she, her, and hers. I do not actually have a PowerPoint presentation. I'm a much more extemporaneous speaker. And as a program, we tend to be a little bit more kind of casual and stuff like this. I was really excited that Annie and Miley, who I think many of you know Miley, she is our PI on this, asked me to come and present since Miley couldn't make it today. So one of the things that I just really want to start out with is I think a number of you have already heard about the study that's being run out of UCSD. Dr. Miley Karras is our primary investigator, and this program is a 3-year study. During our first year of the study, we did a number of surveys, targeted different like elements of the population based on all kinds of demographics. The second year of the study was focused around focus groups, individual interviews, getting some more specific data. And then the third year is the pilot. Now the center has been helping in terms of getting people to complete the surveys, getting people to participate in these various groups. And it's this third year where the center really gets to step in. This is why we're here, is to help run an actual village. Obviously, when we started this study, we did not intend for there to be a pandemic right as we were launching. It has sort of changed the dynamic of things. So while it does say that our village is virtual, it is not virtual by choice. So I feel like that's a pretty key aspect of things. One of the other things that's I think pretty important to note is that with our community, we're targeting and our goal is to have 150 people enrolled in the village and the study, with at least 50 of those people being HIV positive, and then the other 100 can be any members of the community. And so I am here to talk to our folks who are doing the virtual village. I'm sending you all kinds of positive energy since you're just getting started. And I'm going to talk about what it's really like to try and launch a village in a pandemic, because it is not what we anticipated. I can tell you that much right off the bat. So we actually launched our village at the end of December, beginning of January. That's when we did our initial outreach to start recruiting and getting people on board. We've been enrolling people ever since, and we are up to a whopping 27 people in our village, 25 of whom are enrolled in our study. One of the things that we've encountered, and for folks who are already used to working with seniors, it's something that is pretty familiar, I'm sure, that not all of our seniors already have the technology to engage in a virtual village. And in the past, it's often referred to as like a technology gap. Over the course of the pandemic, the other senior serving programs I work with in our community in San Diego, we've come to refer to it as a technology chasm, because that's really how it feels in a lot of regards. We're looking at folks who either do not have access to the technology, may not have familiarity with the technology, or if they do have it, may not have access to the internet, which wasn't something that we had really considered in any serious way prior to the pandemic. I think a lot of us just sort of assumed because we would be doing everything in person, that kind of barrier wasn't going to be an issue. And now here we are trying to get everybody to engage on Zoom. And that becomes much more difficult, not least of all because we have plenty of folks who aren't familiar with Zoom. And it's challenging to tell someone, well, I can teach you how to use Zoom, but you have to get on Zoom for me to teach you, right? So that's one of the things that we've come across. While we have done our best to connect our seniors with other programs in San Diego that are providing computer classes and things like that, again, there's still this sort of like limited learning curve where folks may only be accessing it from their phone, right? We've been really lucky in that recently, starting in December, we've had several grants that have come in, which have allowed us to distribute free Chromebooks to a number of seniors. We've been working really hard to make that happen, particularly for our village members, which has been amazing. And even then, giving out 45 Chromebooks doesn't necessarily make a huge dent in the gap in services that people are encountering. So one of the things that I really want to talk about is just the challenges in enrollment that we've been facing. We have a lot of folks who are interested in the village as a live in-person entity. We're noticing, and I'm sure many of you have heard the term Zoom fatigue, that we're experiencing. You know, students are having it, those of us who are in like 6 meetings a day are having it, and our seniors are having it too. So when it's trying to get people to engage in an activity and they view it as another appointment as opposed to a social engagement, that becomes a significant challenge. One of the things that we've seen, and my colleague Jason is on the call with us today. He is our senior services case manager and is doing all of the enrollment and most of the direct interaction with our village members. One of the things that Jason has encountered is the fact that folks will sign up for the village study because there is a financial compensation aspect to it. And then when we invite them to participate in the village, to engage in the various programs that we have going on, their response is, "No, I'm good." So we definitely find ourselves having to reach out more, having to try harder to get them to see the value in social engagement. Many of these folks are coming to us from the Owens Clinic at UCSD. And so even though they're coming directly from a situation where their HIV status is a part of why they're receiving services, where they may have shared with their service provider, "I'm feeling lonely, I'm feeling disconnected." When provided that opportunity, because that opportunity is over Zoom, they're not engaging in the same way and they're not engaging as much. We're lucky and that because the center is a community center and has an existing senior services program, we were able to kind of fold the village into some of our existing programming. So what that means for us is that we have activities like our Feeling Fit classes, which happen 3 times a week and are provided via San Diego County's Aging and Independent Services. People are doing that over Zoom. We also have things like our monthly lunch and learns. We have some senior social hour kind of events and things like that. And so we've been trying to get our village members to engage in those things. One thing that we have found recently is that if we brand certain things as village specific, so even if they've existed for a while, if we suddenly make it for the village, we get a little bit more of a response, which has been kind of interesting. So one of the things that we have coming up is we're going to be starting in July an online virtual Tai Chi class, which is pretty exciting. That's also going to be provided to us via AIS through San Diego County. And in that particular case, because there's a cap on the number of people in the class, we're actually going to be offering it to our village members first and kind of making a big deal about how they get first enrollment in the hopes that this will help them engage. So that way down the road, when they're actually completing the study surveys and are asked, has being a part of the village improved your feelings of like isolation and loneliness? They'll actually be able to say, yes, I did something, as opposed to, no, it didn't change anything because I didn't participate. So really taking a look at all of those kinds of things. We're also kind of looking at when it comes to what our seniors are after. We got a lot of those questions answered during like our focus groups, during those individual interviews, and what they really wanted even back then was really focused around being in person. So we're trying to evaluate right now how we can start making that happen while also keeping our seniors safe. So there's things that we have had to consider, I think, that are different from some other programs, even just at the center. So we've been talking about doing things like a picnic, right? We have Balboa Park, which is very near the center. It's a beautiful location for those of you who have ever been to it in San Diego, lots of grassy areas. And one of the challenges that we have found is that when we think about it, okay, how are we going to make sure that we keep it limited to the people who have RSVP'd? Right? How do we make sure that we are requiring vaccines without being exclusionary of those folks who may have, especially like social concerns around it when we look at our more diverse populations and we're looking at our BIPOC folks? And then additionally, how do we make sure that folks who have mobility issues are able to get to where the picnic is happening, right? So we also want to take into account the fact that this is something that sets our village apart from most of the other live in-person villages in the country, is that we're completely free. So we're really aiming at that low income, underserved community, kind of that specific population. And so that means that oftentimes along with that come issues of food insecurity, come issues around transportation. So with all of that in mind, we're really kind of having to think outside the box. Additionally, in San Diego, while we're really excited that we have a higher vaccine rate than a few other counties in California, many of us still don't feel like it's really the best policy to start getting large groups of seniors together quite yet. And so one of the things that we're looking at is really how do we ensure that we're doing the social distancing that's necessary. We're hopeful that some of these activities are going to get to happen sooner rather than later. At the same time, we really want to make sure that we're being as mindful of our seniors' safety as possible. Just in terms of a few kind of logistical things, our village starts at age 50, so it's 50 and up. I think our oldest member, who I think is getting enrolled later today or tomorrow, is 90 and a half in his words. And then I think some of our youngest are just now 50. So we really have an amazing age range in that 27 people. Additionally, one of the things that we've noticed is that our village is predominantly men, which makes us very, very different from other villages in the country. Most villages are around 70% women, and they are predominantly white. We're looking to try and make sure that we get as diverse a community as possible, especially because San Diego is so particularly diverse. And so we're looking at ways to really do more enrollment in Spanish. Since I'm a Spanish speaking staff member, we feel like we can provide some of that service. And then down the road, really kind of looking at how do we make sure that we're inclusive of as many people as possible in our recruitment and everything like that. I know that we had 20 minutes. I really kind of, that's like the main part. What I really wanted to focus on was people's questions. I know that there were several of them that showed up in the chat. So I just want to take a half a second. And I see that Thomas has asked, asking about the tech literacy programs. We do work with a lot of programs we're really lucky in that we have Oasis is active in San Diego. They provide senior learning and do like some really amazing stuff. And so we do often connect people with them and their classes. They do have a fee associated with many of their classes, but over the course of the pandemic, they've been switching to shift many of their technology-based classes, so around how to use technology, to free. So we definitely refer people over there. And as often as we can, we try and partner with other organizations in San Diego, particularly like the other nonprofits around, just because we really kind of want to help build that community and ensure that our seniors are really kind of wrapped around in terms of the connections that they have and the care that they receive. And then the whole bit about doing the exercise programs in the park. John, I see you. Sneaky guy. John is really an amazing volunteer at the center, so I know John well. And one of the challenges with that, John, is is that because it's not our instructor, and we have to be able to guarantee the space, and we can't do that in a public park setting because it's a county instructor, they pay the instructor and everything. So for right now, we're remaining virtual. I do know that we are definitely looking at how do we bring that into a single place so we can start having people in person. Where there's been talk about we have a very large parking lot. There's been talk about using our parking lot for some of that kind of stuff. Unfortunately, our parking lot has a lot of loose gravel. So again, it presents some mobility challenges. We don't want anyone to slip and fall. So we're still working on how do we navigate some of that kind of stuff, including reaching out potentially to some local organizations that may have like an enclosed basketball court space or like a garden space where we could partner with them to have it be outdoors but contained, right? So we don't just have like random people walking in. So that's sort of what we're looking at. So John, those conversations are happening. We're just not at a place yet where we can say officially that we're rolling out things being outdoors. And then I see the comment about the low-cost internet. What's challenging for us is that in San Diego previously, there was a service through the Cox cable internet provider, but that has been sort of sunsetted in a lot of respects. And so they're not taking any new enrollments in that, which is challenging. I know that there is new federal funding coming through, which will help pay for broadband up to $50 a month. So we're looking at, and that information isn't really broadly available yet. I used broad like 4 times in that sentence, but it isn't widely available yet. We're not really sure. We don't have the concrete information on how to enroll our seniors in that at this point. So we're on the lookout for that. And really then how do we make sure that that's as easy and as painless a process as possible so we can actually help enroll our seniors in those programs and get them that funding so that they can have the high-speed internet that they need to be able to access things like Zoom or like being able to do Facebook groups and rooms and things like that. So yeah, so those are the chat questions, but I want to open it up and just see if anybody else has any other questions.
Other questions for Elisa? Go ahead and raise your hand or unmute yourself. And while we're waiting, I think you mentioned a program called Oasis that's designed to help train seniors and people who aren't tech savvy and how to use these platforms. Can you describe a little bit how that works and what it does? Because I know many of us, you know, in the last year have had to switch to Zoom, and we've all lost clients because they don't, you know, for all the reasons you described, or they just don't want to. I know we have one who he can afford the equipment, he's got a nice phone, he's got the internet, he just does not want to do Zoom.
Yes. So Oasis is actually a national organization. They provide adult learning classes specifically for seniors. They have classes, I guess you could say they have chapters in various states and cities all over the US. Technology education isn't their primary function, though they do have technology classes. They've actually been offering more of them over the course of the pandemic. I see John's question about Oasis being all online right now. They are predominantly online. However, they are just now starting to offer a couple of things in an outdoor capacity. I don't think those will be happening until June, but they've just now started advertising them. So what you can do is, and I know like for San Diego, it's oasissd.org, I believe. And so that's the website for the San Diego County. If you look up Oasis Senior Learning or Oasis Senior Education and do a quick Google, it'll let you know all the different parts of the country that they're in. And their classes have been kept relatively small, which I think is really helpful. And so some of the classes have also been pre-recorded. So it's essentially like going on to YouTube, watching how to do it, and then kind of navigating it on your own. And so while that's not the best in the world, it's better than nothing. It's also really prompted us at the center to take a look at the sort of things that we're offering to our seniors so that when we're back in person, we're really going to be prioritizing technology education. We have a huge number of volunteers at the center. So we're really looking at how do we bring those volunteers in and have them tutor, work with our seniors in terms of the computer, tablets, phone, all that kind of stuff, so that if we ever end up in this situation again, or if we have a senior who becomes homebound, they're able to stay connected in the future. That definitely falls into that. It feels like a little too late. And at the same time, it's really forced us to recognize a number of things around how we're providing services. And that's, I think, going to change how those services are provided in the future.
Great, thank you.
Yeah.
Tom, I see you have a question.
Yes, I just wanted to mention as a follow-up to Elisa's comment, you may want to look into the offerings from OATS, the Older Adults Technology Services. They're focused specifically on tech literacy for older adults. They offer both online and in-person when that's possible through local chapters, and it's free.
That is wonderful. I haven't heard of them. Thank you so much.
No, and they recently were a nonprofit. They are a nonprofit. They've recently joined or merged with AARP as a vehicle to help them scale up more quickly on a national basis from their initial hometown of New York City. But they are located they have programs or partnerships in other locations. They've done a program already with ACREA and GHMC on HIV prevention for older adults.
Oh, awesome.
A module that they already offer, but they have lots of other things. So it might be something worth looking into.
Yes, no, I've already written it down. Thank you so much.
You're welcome.
Thank you.
Just to reinforce, we've had a great experience well contacting.
Excellent. Thank you.
Anyone else with a question for Lisa? And while we're waiting, I had, you mentioned the advantages of being embedded in the center and having a big volunteer pool. Is there an intergenerational aspect of this? I know, like, kind of a standing joke among seniors is, especially LGBT seniors is, oops, I didn't have grandkids and I have nobody to program my device for me. So
Yes, for sure. It's my wife and I joke about what we're going to do one day when what do we do when the technology changes? That's actually definitely something that we are hoping to incorporate more, especially as we come back to being in person. It's one of those things where, and I'm sure other people who work in similar settings have heard similar feedback, is that when we emphasize the intergenerational or the youth component of things too heavily in the beginning for senior programs, our seniors don't enroll because they feel that the program is no longer for them. And so we often hear that, well, everything's youth focused, everything's about young people. Why isn't there anything for us? And so we really want to make sure that we're highlighting the distinction between village membership and village volunteering. And our volunteer programs were essentially put completely on hold for the last year. And so while there has been new volunteer orientations and things like that, there hasn't really been volunteer recruitment happening over the last year. And while we have had some new volunteers join the center, predominantly it's sort of stopped. And so as we go forward in the future, our hope is that we'll be able to then, because now we're finally getting to the point where we can start adding more volunteers and kind of doing some of that kind of stuff. So the intergenerational component is going to come predominantly from our volunteers who will be able to, we're using the Helpful Village software as our, for those of you who aren't familiar, it's a village specific software that allows our seniors to come in, take a look at activities that are happening, request support and services. And then on our end, we can actually track that data, which is really helpful. And then our volunteers, if they're signed up specifically as volunteers, log into the website and they can see any requests for support. So say someone needs a ride to a doctor's appointment. They can say, hey, I'll claim that one, and go ahead and they'll be that person. One of the other advantages that we have in that we're a part of the center is that the center does all the background checks, does all that vetting of our volunteers, so we can really be much more secure in who we're allowing to connect with our seniors. And so that's really helpful. And that's one of the things that we're hoping will bring in that intergenerational component.
great, thank you. And that Helpful Village is a great resource. I wasn't aware of it, so already posted
Yes.
it to folks. And
Yeah. For folks who are starting a village, I highly recommend reaching out to Manuel. He is the owner operator of Helpful Village. He and his staff are really excellent. And it is specific to villages. It's not some other database or tool that's then been modified to work with villages. This was created from the ground up for villages and specifically is designed to be as user-friendly for seniors, even seniors with sort of a low technology aptitude as possible. So we're really liking how it works.
Excellent, thank you. Any other questions or comments? Again, thank you to our speakers for staying on time. We're actually a few minutes ahead of time, so that's good. Annie.
And real quick, I just wanted to mention that I'm going to go ahead and put the link to the website for the UCSD Center Village Study, so that y'all can check it out if you're interested in, and also provide you some contact information for me and Elisa, if you want to reach out to us for more conversation and information.
Great, thank you, Jason.
Thank you so much.
Thanks.
Thank you, Elisa, for that presentation. And that was a great presentation without slides. So thank you for mixing up the format a little bit. Associate Professor in Infectious Diseases at the University of Colorado. Her clinical and research interests are in improving the physical function and quality of life of older adults with HIV, and she will be speaking to us today about exercise interventions. So Kristine, take it away.
Thank you. Am I sharing the right screen? You guys see my slides? Okay. So thank you for the introduction. I'm happy to be here today. Apologize for the late arrival. We actually had an exercise study visit right before this. So, okay. So to start out, I want you guys to imagine that there's a magic pill that could mimic all of the beneficial effects of physical activity. Unfortunately, we don't have that magic pill yet. And as this doctor tells his patient, to treat your high blood pressure, diabetes, hyperlipidemia, and osteoporosis, take this new pill every day. However, it's not a pill that you can swallow. Take it out for a jog, and then take it to the gym, and then take it for a bike ride. So in other words, we really have no substitute for the benefits of physical activity at this point. I just wanted to start with a few definitions to make sure we're kind of all on the same page. To start, I'm going to talk about physical activity as any body movement generated by contraction of skeletal muscles that raises energy above rest. So basically anything that the body's doing above just sitting there. Physical inactivity is when there's a non-achievement of specific physical activity guidelines. So the CDC tells you you're supposed to exercise a certain amount of minutes each day. If that goal is not reached, then that's considered physical inactivity. Exercise is specifically the type of activity that's planned and structured and favoring physical maintenance, physical fitness maintenance. So basically going out for a jog for the purpose of improving one's health, kind of planned that you're going to go for a certain amount of time. There's a structure to it. And then sedentary behaviors, which we've heard a lot more about in the last few years, are any behaviors that are characterized by a really low energy expenditure. So essentially sitting, laying, reclining. So where do we get guidelines about how much physical activity is enough or too much, or well, not too much, but how much is enough or how much is recommended? And there's a couple of different organizations that tend to put out these guidelines. One is the Centers for Disease Control and Prevention, and the other is the World Health Organization. World Health Organization being more of the global guidelines. And importantly, the World Health Organization's guidelines that were updated just a few months ago in December had some really interesting updates that I think emphasize ways that our thoughts about physical activity and exercise have changed over the last few years. So this set of guidelines actually has a lot more emphasis on physical activity. So essentially any activity that's not sitting, and much less on that specific term exercise. So that's structured kind of specific goals for exercise that go out and go for a jog, go for something that's other than just sitting. They also have specific recommendations in the guidelines for the first time on people with HIV, listed as one of the chronic conditions, which is exciting that I think there's a recognition of HIV in the guidelines. And then instead of saying that everyone needs to do 150 minutes of moderate or 75 minutes of vigorous physical activity or exercise, they actually just say everyone should have a minimum of 150 to 300 minutes per week of physical activity. And they really emphasize that more is better. So not necessarily that minimum amount of what's good, but the more you can exercise, the better. And then also new this time in the guidelines is this emphasis on doing anything to decrease sedentary time. So even just standing while you're on this Zoom call to get a little bit of physical activity rather than just sitting. So this begs a question, is physical activity, inactivity, or sedentary behavior really a problem in people with HIV? And I would argue absolutely. I think this is a problem probably with people without HIV just as much as people with HIV. But we do see that several studies show that people with HIV have possibly even more inactivity or sedentary behavior than the general population. One study found that people with HIV spend about 9 hours a day in sedentary behavior. They have some of the highest levels of sedentary behavior reported in the literature in comparison to other comorbid conditions. And we know that that sedentary time or just sitting is associated with poor physical performance. We also know on the flip side that physical activity or exercise are consistently associated with improved or higher physical function, and that physical activity is really one of the only effective interventions that we have for improving physical impairments and frailty. So I want to spend a little bit of time today talking about 3 different studies that we've been working on or recently completed in Colorado: the Exercise for Healthy Aging, Health Well, and Health Studies. And just to give a little bit of background, Colorado is a bit different. I think those of you in Palm Springs also have kind of this oasis But we have this gorgeous mountain view, as you can see in the picture. We have some of the most sunshine of anywhere else in the country, so 300 days of sunshine a year. We have actually fairly mild winters, despite what people think, with our average high of about 49. And then our summer highs get pretty hot, but it's a dry heat, so much more pleasant. So we certainly may have different physical activity behaviors in Colorado than other places in the country. We also, as you can see in the green color in the middle of the map, have some of the lowest rates of obesity in the country, with the only other states having obesity rates in that 20% range being the DC area. So keeping that in mind as you think of how our participants may or may not respond to exercise. So when I first started out, I had a strong focus, or when I started out in my research time, actually during my fellowship training, I was really interested in frailty. And one of the things that we kept consistently seeing is people that were frail or had low physical function, and it was strongly associated with low physical activity. And so one of the things I really wanted to investigate was how much can we improve frailty with exercise in people with HIV? And even more so, can we exercise, is more intense exercise actually better? Or if we give people too intensive exercise, are we causing higher levels of inflammation, more injury, more fatigue, and actually people don't improve with higher intensity? So the Exercise for Healthy Aging study was really focused on whether more intense exercise can lead to better improvements in strength and endurance. For this study, we enrolled 70 total people with HIV and unaffected control, so about 35 in each group, between ages 50 and 75. All of our participants came into our research gym, which is attached to the hospital. We have, they all completed 3 times per week supervised cardiovascular and resistance exercise in the gym. So there was someone there kind of watching over to make sure they were doing things correctly. And that first 12 weeks of the intervention, they exercised at what we called a moderate intensity of exercise. So kind of targeting a moderate heart rate and a certain amount of weight that we would have them lift. After 12 weeks, we randomized half the group to continue at that same intensity of exercise and half the group to advance to a more intense, high intensity exercise. So to go over a few of our changes, this is the short physical performance battery. The short physical performance battery includes a short gait speed assessment, a balance test, and time to rise up from the chair 5 times. A score of 12, shown in the blue bars here, is a perfect score. And as you can see, we had actually quite a few people that had a perfect score at baseline, both in our people with HIV and our controls. Over half of those with HIV had a perfect score at baseline. We did have about 40% that had some sort of impairment. And as the bars move over to the right, it shows the changes that we see after week 12 and then after week 24. And you can see we definitely did see an improvement in short physical performance battery scores with time. We also looked at frailty. We actually ended up getting a little bit healthier group for this study. And so we didn't have anyone that had frailty, but we did have a large proportion of our participants that were pre-frail at starting exercise. So of the people with HIV, this bracket here shows those that either had 1 or 2 components of frailty, so met criteria for pre-frailty, which was a good almost 80% of our population. And that those pre-frailty components decreased at week 12 and week 24 with exercise. Interestingly, we didn't really see that much of a change among the controls, which I'm not really sure why, but they had a pretty similar rate of pre-frailty even after exercise. Then we also looked at several different physical function markers. So you can see all the markers that we looked at along the left side here: chair stand time, time to walk 400 meters, time to climb a flight of stairs, some specific weight measures: bench press, leg press, lateral pull down, and then a measure of exercise endurance, which is the VO2 maximum. The red bars here demonstrate the people with HIV and their improvements. The black bars show the HIV uninfected controls. And then the first part of the bar, kind of in the darker color, is how much improvement we saw in the first 12 weeks. And then the second part of the bar is the additional improvement we saw after the extra 12 weeks. So a couple of things to note is that kind of across every test, we saw the most improvement really in the first 12 weeks. So just 3 months of exercise, and we're seeing pretty impressive improvements in physical function across almost all of these different tests. The second thing to look at is that we saw pretty good improvements on almost every single test that we did, ranging from about 10% to up to about 45% improvement in some of these measures like bench press and chair stand time. And then the other thing is that we actually saw really nice improvements in everyone. They were pretty similar between a lot of the studies in both the people with HIV and our controls, but we saw significantly greater improvements in a few tests among those with HIV, that being the faster 400-meter walk time, faster ability to climb a flight of stairs, and greater endurance in that VO2 max time. So really impressive improvements across the board in lots of functional measures with even just that 12 weeks of exercise. As I mentioned, one of the big things we were interested in is how much does high intensity exercise help? And this wasn't high intensity interval training per se. This was just a little bit more weights and targeting a higher heart rate. And across the board, we saw that those with HIV who were randomized to a high intensity of exercise, the blue bar here, tended to have a greater improvement in their measures of physical function compared to those with a moderate intensity of exercise, with the exception of the chair stand time, which were actually slightly better in the moderate intensity group. So you can see, for example, bench press, those that were randomized to high intensity exercise had about a 20% improvement versus about a 12% improvement with moderate. So essentially, the more intensely and the more that you're exercising, the greater improvement you're going to get in these physical function markers, not getting necessarily more injury or more fatigue. So it seems like more is better. We were also interested in changes in body composition. So here you can see the percent change in lean mass or fat mass, the red circle being those with HIV and the blue square being the controls. And both groups had an increase in their lean mass, so a kind of a proxy of skeletal muscle mass. And then both groups had a decrease in the amount of fat, being greater actually in our folks with HIV. Sometimes questionnaires don't necessarily kind of capture everything that people are noting with their improvements. And we did several questionnaires on depression and sleep and kind of quality of life, and actually didn't see a lot of great changes. Some of that can be someone's having a bad day that day, and the questionnaire is kind of asking, how do you feel today? And so it may not reflect the benefit of 6 months of exercise. So another way we kind of wanted to tease out how people were feeling with exercise and how exercise was changing their behaviors was through qualitative interviews. So we interviewed about half of our participants, actually just our participants with HIV, somewhere between about week 4 to week 24 of the exercise intervention, and asked them some of the things that they thought had changed with exercise. I included some of the key areas that we felt like people were improving in, being confidence, mood, and energy. And just some, I could have pages and pages of quotes that we had that were just really remarkable, but a couple quotes that I thought really reflected people's feelings of how they felt with exercise. The first one here, someone noted that he had improved confidence. He said, I didn't think I could or even wanted to walk for a half an hour. I was thinking 20 minutes and then a half an hour and then 40 minutes and then 50 minutes. I've never done that before, and it gave me encouragement that I could do it. So I think having that supervision, having folks have a trainer one-on-one that they could work with really helped with their confidence with exercise. In terms of mood, one gentleman said, I am more positive, I'm more forgiving of the things that are going on and more grateful of the things I have. And another said, it's just, I think it pulled me out of always wanting to be alone, which I think is a really key point for a lot of the social isolation we're experiencing right now with COVID. And then some energy levels. This was one of my favorite quotes. Normally, and I can just picture this person saying it, but normally it was like, find me a chair. I mean, now I have more energy. As I mentioned earlier, one of the things we were really interested in was, does higher intensity exercise actually cause more muscle damage and increase inflammation? We know that if someone goes out and runs a marathon or does something very intense, it can actually lead to greater inflammation. And so did we see that same effect over time? I just included a few of our interesting inflammatory markers here. We also looked at IL-6, soluble TNF receptor 1 and TNF alpha, and saw some changes kind of similar to what we see here. But to highlight a couple of key points with our inflammatory markers, This kind of maroon colored circle shows people with HIV that were randomized to a high intensity of exercise. And you can see this is actually the only group that really has a decrease in CRP with exercise, is this group of people with HIV that are randomized to a higher intensity of exercise. So again, emphasizing that point that more exercise actually does appear to be better and is decreasing this important inflammatory marker that's been associated with cardiovascular disease and many other outcomes in people with HIV. The other interesting finding we saw was this IL-10. IL-10 is an anti-inflammatory cytokine, so we actually want it to increase with exercise. It's a good thing. It kind of helps to balance out other cytokines. And interestingly, we kind of saw a blunted response in people with HIV. We didn't get that nice anti-inflammatory effect, and we're not really sure why that is. We did see a little bit of it in the moderate group, but really not much of an increase in this anti-inflammatory cytokine. And the other interesting finding was soluble CD14. We saw that both groups randomized to high intensity exercise actually had an increase in their soluble CD14. Not really sure what to make of this, if it's causing gut breakdown because of the high intensity exercise, but soluble CD14 is an inflammatory marker or a marker of immune activation that has been associated with poor outcomes in people with HIV. And I couldn't find much at all on soluble CD14 in exercise, so I'm not sure how to interpret this, but if anyone has thoughts, I'm happy to hear your thoughts. This is kind of a busy slide, but I'm going to point out a few key things on the figure. One thing we were interested in is if people are coming in and exercising with us on, say, Monday, Wednesday, Friday, are they exhausted and sitting on the couch on Tuesday, Thursday, Saturday, Sunday, and not exercising at all? So are we actually making people less active on the days that they're not exercising? So we gave all of our participants pedometers. I will say that not very many of our participants didn't lose or wore their pedometers throughout the whole study. So this is a limited subset of people who actually held on to their pedometers for the whole duration of the study. But this is looking at changes in step count from the beginning of the study to the end of the study. And the top two solid bars are showing what people's exercise is doing on the days that they're coming in to exercise in our center. And then the dotted lines are showing what people are doing on the days that they're off, that they don't have to come in and exercise with us, but we encourage them to be active at home. So a couple key points. We found overall that this black line here shows that people with HIV were actually a bit less active on their exercise days than our controls, even when we were giving them this specific prescription of how much to exercise. We also found that our folks with HIV tended to improve their activity levels a little bit less throughout the duration. So this line here is a little bit flatter than the top line. And then down at the bottom, when we look at those two dashed lines, we found that those with HIV were actually a bit less active as well on their non-exercise days. So even when we have this specific script and we tell people how much to exercise, it seems like we're not quite getting to those same activity goals in our group with HIV compared to our uninfected controls. So I think something important is trying to increase activity even on our non-exercise days and having at least some level of activity every day. So 3 months after we completed the study, we went back and called all of our participants or emailed them and said, how many of you are still exercising? And we were very disappointed to find out that despite all of these great improvements people were having in physical function and mood and energy, less than half of our participants were even exercising 1 day a week or more. And so this led us to think, what can we do to keep people exercising? We had this great intervention, center-based, got everyone in and exercise, but then they all kind of quit towards the end. And so we created an exercise prescription with a group of other folks around the country that were really interested in exercise, including actually several folks in San Diego, for providers to use. And this is a prescription that was published in the journal AIDS and can be printed out as a PDF and given to patients. And it goes through suggestions for how to gradually increase exercise and set some goals. So this was one step. The other step was I talked to one of our AIDS service organizations, the Colorado Health Network in the Denver area, and we submitted some local funding with one of our aging organizations and supported this program that we called HealthWell. We were supposed to start the program in March, and this was going to be just a way to try to improve steps and physical activity in a small group of folks using some pedometers and just kind of using basically this exercise prescription to try to increase step count. Unfortunately, it was supposed to start right at the same time that COVID hit, and so we converted everything to a virtual program and had an 18-week program that included several different virtual components. We had weekly Zoom meetings with education on topics, anything related to aging like sleep, advanced directives, wills, lots of different topics. All of our participants had the opportunity to have one-on-one meetings with a dietitian. And then one of the highlights of the program was that we were able to work with the Denver Botanic Garden and do outside guided walks. Masked, people could stay socially distanced, but I think it gave a really great opportunity for doing something active while having a safe distance, being able to have a social activity and learning something about the gardens and the different plants in the area. All of our participants received a pedometer, and then together their steps tried to traverse the Pacific Crest Trail. So our combined step count almost made it from the northern end of Washington to the southern end of California, but not quite. We just started round 2 of this with another virtual intervention with a few edits to try to improve some aspects that participants gave us feedback on. But I think just trying out different programs to see what we can do to help people be more active. And then the other program I wanted to briefly mention is our health study. And so one question that came up from our other study was, are there different types of exercise that might be more appealing, make people less bored, kind of catch people better so that they're more likely to keep exercising? And there's a growing interest in high intensity interval training, or HIIT. Several studies have shown that HIIT may have actually better cardiovascular benefits with some diseases like diabetes. People might have a greater improvement in mobility compared to other types of exercises. It may decrease fatigue. And several studies have noted that participants feel that HIIT is less boring than kind of typical treadmill exercise. And so this is our study. We actually just started enrolling for a couple of months ago. Our goal is to enroll 100 people with HIV aged 50 or older. We have 2 sites, both at University of Washington and in Denver. And this will be 16 weeks, so a little bit shorter than our prior intervention, comparing HIIT to the same moderate intensity of exercise with focus on physical function and fatigue. And then thanks to Jeff and many of the group in San Diego, we had a lot of feedback from the community and from providers in the area on our mHealth intervention and kind of refined this a bit. After the in-person intervention, we will have some text messaging. Our participants will get Fitbits and have some guidance to kind of continue their exercise and hopefully bridge them from this center-based exercise to sustained physical activity behaviors. So in summary, we know that people with and without HIV have high rates of physical inactivity and sedentary behavior. Physical activity is safe and highly effective for people with HIV to improve their physical function. I think we all find that habits are hard to keep, and we really need some creative ways to help people engage with exercise and develop lifelong habits so that they can enjoy the lifelong benefits. I'm happy to take any questions.
Terrific. Thank you, Dr. Erlandson. That was amazing. So we're running a little behind, but I'll take one question and then we can save the rest for the end. So Dr. Davtyan, I see your hand up. Go ahead. Mariam, there.
Yeah, can you hear me?
Mm-hmm. Go ahead.
That was a fantastic presentation, Dr. Erlandson. Just one question. Did you appraise viral loads in the HIV patients? Were the patients virally suppressed?
Yes, for all of our studies, we've only included folks with viral suppression. We used a more liberal cutoff of 200. We didn't require less than 50, but we wanted people that were on antiretroviral therapy to really capture that group that we can further improve their function.
Okay, great. Thank you very much.
Mm-hmm.
Great, thank you. So in the interest of time, I think we'll forge ahead and we'll still have some time at the end for questions for all our second session presenters.
Yeah, and I do see a couple of questions or comments in the chat, and so maybe Dr. Erlandson, you can respond to those there. And I will be introducing our next speaker, and that is Mariam Davtyan. Dr. Davtyan is an assistant professor of research pediatrics at Keck Medicine of USC. Her primary research focus is on HIV-related stigma and its clinical and social outcomes in diverse populations, including women of color living with HIV and long-term HIV survivors. Dr. Davtyan's most recent research has examined the role of resilience factors, such as personal mastery, mindfulness, and social support in the lives of older adults living with HIV and the psychosocial determinants of COVID-19 vaccine acceptability. So you should be able to screen share, and the floor is yours.
Thank you very much, Annie. Appreciate it. Let me share my screen here. Okay, let's see here. Okay.
We can get rid of math.
Okay, let's see. Can you guys see my screen?
Yes.
Okay, perfect. I'm super excited to present some of the results of our research. So the title of my presentation is the determinants of COVID-19 vaccine acceptability in older adults living with HIV in the Coachella Valley. And I'm going to begin by giving you a very brief background on the COVID pandemic, some numbers. And so on March 11th, 2020, the WHO declared the outbreak of the novel type of coronavirus that causes COVID-19 respiratory disease a global pandemic. To date, approximately 160 million people have been infected with SARS-CoV-2 worldwide, and more than 3 million people have died. In the United States, approximately 30 million people have been infected, and we have seen over 500,000 deaths. So here are some of the risk factors of severe COVID-19 illness. This is not an exhaustive list. These are just some of the main risk factors that were available on the CDC website. So older age, chronic kidney disease, chronic lung disease, diabetes, obesity, and HIV have been identified as risk factors. So the contribution of HIV to COVID disease outcomes is unclear. There's limited data, and the data are continuing to be published. So we will see in the upcoming months what's really happening, but the available data are very mixed. The results are mixed. There's some evidence that suggests that people living with HIV are not at an increased risk for SARS-CoV-2 infection, severe disease, as well as death. So here's a study of matched HIV patients with non-HIV controls that was done at NYU. These patients were with COVID disease, and those with HIV did not have, there were no significant differences in outcomes in the HIV patients, even though there were increasing trends in intensive care unit admission, ventilation, and mortality in HIV positive patients. So when you look at other studies, they show that HIV patients may in fact be at higher risk for SARS-CoV-2 infection, severe COVID-19 disease, and death. Here's a study of COVID-19 outcomes among people living with HIV in New York State. And this study found that those living with HIV compared to without were more likely to receive a diagnosis of, be hospitalized, and die in hospital with COVID-19. But what has remained somewhat consistent is that the risk of adverse COVID-19 outcomes tends to be lower in people with HIV who are on antiretroviral therapy. Here's one study that looked at tenofovir-based regimens. And so people who are on their medications, are virally suppressed, tend to do better. At least that's what the evidence has been showing. So let's talk a little bit about the current COVID-19 vaccines. I know that there are some additional ones, but on December 11th and December 18th of 2020, FDA issued the first emergency use authorizations for 2 therapeutic vaccines, right? The Pfizer, BioNTech, and Moderna COVID-19 vaccines were made available and allowed for distribution in the United States. So to date, approximately 260 million vaccines have been administered in the United States. I'm sure everyone is familiar with who Dr. Anthony Fauci is. And I remember seeing Dr. Fauci speak, and he said that approximately 80%, the US population would need to be vaccinated for us to reach population immunity or herd immunity. But the more recent information that has been provided by the NIH and the CDC is that it's unclear when or if the United States will reach herd immunities. We have different types of the virus, variants of the virus that are spreading in our community. So it's hard to say right now when we will or if we will reach population immunity. So even though we're very lucky in this country to have access, at least for the most part, to the COVID vaccine, we have seen significant disparities in the distribution of the vaccine as well as the uptake of the vaccine. So the data are very interesting. So and expected actually. So the data indicate that African Americans and Latinx people receive smaller shares of the vaccinations compared to their share of cases and deaths. Here's an example. In California, 21% of vaccinations were administered to Latinx, even though that population comprised more than half of cases, almost half of deaths, and 40% of the total state population. Similarly, while making up nearly 40% of cases, nearly 80% of deaths, and nearly half of the total population, African Americans received only 30% of vaccinations in the District of Columbia. So, and we're also seeing very high levels of vaccine hesitancy among African Americans and Latinx populations, and I will discuss these now. So what are the determinants of COVID vaccine hesitancy? What makes people hesitate to get the vaccine if it becomes available? So these are all, not all, but some are expected and some are, far-fetched. I mean, depending on who you ask, but the number one reason why people have been hesitant or apprehensive about the COVID-19 vaccine is concerns about potential harm and side effects. And some other reasons include just lack of confidence that the vaccine is safe and effective. And people say that because it was developed and approved in such a speedy time period that perhaps the scientists that engineered the vaccine were cutting corners. And even though the vaccine has been tested in thousands and thousands of people, there is still this concern that, corners were cut in order to expedite the process of having the vaccine available. There are folks who have just general low confidence in science and scientists, which is very upsetting and very alarming. Also, mistrust of government motivations and transparency around COVID-19. Is the government being honest about the vaccine and whether it's actually safe or effective? These are some interesting findings in the literature. Self-identification as a Republican and exposure to conservative news seems to be a predictor of vaccine hesitancy. We have seen things such as beliefs about racism in healthcare, particularly among African-American populations, and that being that anticipated racism in healthcare systems being a reason for hesitating to get the vaccine if it becomes available. These are some things that came about in research in Ireland and in the United Kingdom. Low levels of altruism, higher levels of religious and conspiratorial beliefs. And also, this was interesting, lower levels of a personality trait, agreeableness. So here are determinants of COVID-19 vaccine acceptability. What makes people actually, what does the data indicate about who are the people who actually accept the vaccine, right? So we've seen data that indicates that males versus females are more likely to get the vaccine. Older adults versus younger adults. This makes a lot of sense since, risk of COVID and complications are higher among older adults, right? In terms of racial predictors, Asians compared to other racial and ethnic groups are more likely to get the vaccine. College and or graduate degree holders compared to those with less than a college degree more likely to accept the vaccine. Risk perceptions, thinking that COVID-19 could actually be very, very severe and that everyone is susceptible. Those predict vaccine acceptability. Verified vaccine safety and effectiveness. If people are, explained by providers, by their clinical team, by their social work team, mental health team, that the vaccine is safe and effective, they're more likely to get the vaccine. We also see lower income as a predictor of vaccine acceptability and overall trust in the healthcare system. So what is COVID vaccine, this phenomena, how does it translate into people living with HIV? So when you do the literature review that I did to look at vaccine related papers, there are very few that have actually examined vaccine hesitancy in people living with HIV. Here's a couple that I have that I will share with you. So this is a study of
Sorry, Mariam, you need to unmute. Something happened.
Oh,
there you go. Now you're back. Sorry about that.
Okay,
I'm going to
no
repeat the
problem.
last sentence.
I apologize. It's my dog, Snoopy. She's just barking away. I'm really, really sorry about that. So only a few studies have examined COVID-19 vaccine hesitancy in people with HIV. Here's one study of antiretroviral adherence in African Americans in LA County found that 97% endorsed at least one COVID-19 mistrust belief, and over 50% endorsed at least one COVID vaccine or treatment hesitancy belief. Similarly, a study of people living with HIV in France found 30% vaccine hesitancy prevalence, and this was attributed to general vaccine refusal, concerns about side effects, and the belief that they were already immune to COVID-19. So there are currently no published studies on the determinants of COVID-19 vaccine acceptability in people living with HIV in the US. And there's certainly no studies examining the role of not just demographic variables, but HIV disease characteristics as well as psychosocial characteristics in COVID-19 vaccine acceptability in people living with HIV. So to contribute to this, well, before I get to why we did this study, but so let's just take a moment and talk about older adults living with HIV, why it's so important to study this, this particular segment of the population. So as of 2018, older adults aged 50 years and older comprise more than 50% of all people living with HIV in the United States. And Coachella Valley, which is where our study took place, is home to 50%, over 50% of all people living with HIV in Riverside County, which is the fourth largest county in California. And approximately 24% of people living in this region are at least 60 years of age. So older adults living with HIV face a plethora of barriers and social and medical complexities. We've already talked a little bit about this: living alone, intersectional stigma that, across HIV and ageism. People face structural inequalities, food and housing insecurity, social isolation, and of course, comorbidities. So higher risk of COVID, with age, risk of COVID increases. And older adults with HIV at higher risk for are at higher risk for comorbidities that may further complicate COVID-19 outcomes. And so also this particular segment of the population is very, very understudied. So to fill these gaps and to contribute to the literature on vaccine, COVID-19 vaccine acceptability, we decided we were already collecting data in Coachella Valley on HIV, people living with HIV, older adults living with HIV, looking at stigma and other factors like mindfulness and mastery and social support and depression. So we decided to take advantage and include a survey item on COVID-19 vaccine acceptability. So our study objectives were to first estimate the prevalence of COVID-19 vaccine acceptability in older adults living with HIV. We also wanted to examine demographic HIV disease and psychosocial determinants of COVID-19 vaccine acceptability. So as I said, this was an ongoing study that was approved by the Health Sciences Campus Institutional Review Board of the University of Southern California, USC. It was a completely anonymous online survey. No identifiable information was collected, and participants were given a $20 electronic gift card for participation in the study. So as I said, during the pandemic, we amended the survey to include one item on COVID-19 vaccine acceptability. And this item that we developed was developed by the Heart Palm Springs affiliated community members and researchers. So the inclusion criteria for the study was at least 50 years of age, living with HIV, and residing in Coachella Valley. So we developed a recruitment flyer in collaboration with the Stakeholder Advisory Board of Heart PS. And the flyer was disseminated to local AIDS service organizations. The flyer contained a link and a QR code that people can scan and access the survey, which not only the survey, but an information sheet that included the purpose, duration, procedures, compensation, confidentiality. If prospective participants met the inclusion criteria, then they were directed to a one-time anonymous electronic survey that was hosted by USC Qualtrics, which is an online survey platform. So here are the variables of interest. This is what we looked at. In terms of measures of exposure, we looked at demographic characteristics such as age, race, ethnicity, gender identity, marital status, living arrangement, income, education, employment status, and physical disability. In terms of HIV disease factors, we looked at years living with HIV, history of AIDS diagnosis, and viral load. In terms of psychosocial factors, as I mentioned, we looked at stigma, social support, depression, mindfulness, which is defined as being present in the moment, ageism, and personal mastery, which is perceived control over life events. And we wanted to see how these characteristics, how they were associated with our outcome measure, which was COVID-19 vaccine acceptability. And so participants were asked to indicate their level of agreement with one statement, which was, "I see no problem with receiving a COVID-19 vaccine if one became available." So I won't focus too much on the data analysis, but these are some of the methodologies we used. Descriptive stats to define the characteristics of the population. We looked at mean differences in COVID-19 vaccine scores, associations between the COVID vaccine variable with the categorical demographic HIV disease and psychosocial characteristics, and then looked at the individual and cumulative sort of relationship of the exposure variables to the COVID-19 vaccine variable. And so then statistical significance was evaluated at less than or equal to 0.05. So here are some of the demographic characteristics, but before I go into this, I just wanted to reinforce that between October 2020 and February 2021, 116 older adults living with HIV in the Coachella Valley completed the survey. And we had data on vaccine acceptability in 114 of those, right? So then the mean age of the respondents, the average age was 62 years, 83% self-identified as man, 74% as gay, nearly 80% white, nearly 90% non-Hispanic, more than half married or domestic or in a domestic partnership, half were living with a partner or a spouse, About a quarter had less than 20,000 annual household income. 96%, over 96%, actually, yes, 96% have more than a high school education. About 40% were employed and 34% were retired, and over a third reported a physical disability. So here are some of our results. So these are the HIV disease and psychosocial characteristics. So the mean years living with HIV in our study population was 23 years. This was very encouraging and so great to see that 86% had an undetectable viral load. Over 60% had a history of an AIDS diagnosis. This was also encouraging. 87% had at least some social support. This was upsetting, but nearly 80% had at least mild depression. About 60% had low levels of mindfulness. Over 90% had low levels of HIV-related stigma. 72% had never experienced ageism or age-related discrimination, and over half had low levels of personal mastery, which is perceived control over one's life events. So in terms of vaccine acceptability, overall, 75% of the respondents agreed or strongly agreed with the COVID-19 vaccine acceptability statement, which is a high prevalence. And then we saw mean vaccine acceptability scores that were statistically significantly higher in those who self-identified as man, as gay, white, non-Hispanic, living alone, single, having a household income of less than 20,000, having a graduate or professional degree, those who were retired, reported a physical disability, had been living with HIV 30 to 39 years, those who reported a lot of social support, low HIV stigma, and high mastery. So these are the key findings. So as I said in the beginning, we looked at each of the individual exposure variables and their association with the COVID-19 vaccine acceptability variable. And we saw that ethnicity, years living with HIV, depression, stigma, mastery, sexual orientation, gender identification, living arrangement, income, and employment were individually associated with COVID-19 vaccine acceptability. But these are unadjusted models. So when we looked at all these variables that were significant in the univariable model, when we included them in the multivariable model, meaning we looked at all of the variables together, only longer time living with HIV was significantly associated with increased COVID-19 vaccine acceptability when controlling for the other variables in the model. So the way we interpret this is that with 1 unit increase in years living with HIV, COVID-19 vaccine acceptability increased by 8%. So in that same model, we also saw that higher level of mastery was associated with increased COVID-19 vaccine acceptability, but the significance was marginal. So it was greater than 0.05. So the way we interpret that is with 1 unit increase in personal mastery, which is your perceived control over your life events, COVID-19 vaccine acceptability increased by 16%, though the significance, as I said, was not marginal. So this is really interesting and really warrants further exploration, I think. And so there are some study limitations that are important to consider. This is a cross-sectional study, so we cannot make causal inferences or draw causal conclusions, right? The study sample was largely virally suppressed, consisted of white individuals, non-Hispanics, those who self-identified as gay, male, and with high levels of education. So we have to think carefully about generalization. And generalization would be difficult because experiences of vaccine acceptability may be vastly different in other older adults living with HIV who did not, whose demographic characteristics were different. So also, we use validated scales to measure things like stigma and things like mastery and mindfulness and depression and social support. But we have to acknowledge that these scales are not perfect, and that many of these scales or some of these scales may not have captured the nuanced experiences of older adults living with HIV. So here are the conclusions. We saw that the prevalence of COVID-19 vaccine acceptability was high in this segment of this population of older adults living with HIV in Coachella Valley. We found that the longer someone has been living with HIV, the more likely they are to accept the COVID-19 vaccine, which is interesting, but we have to think about how is this meaningful clinically and contextually. And higher levels of personal mastery were associated with increased COVID-19 vaccine acceptability, but the significance was marginal. So here's some of the implications of these study findings for further work. So as I said, longer time living with HIV predicted COVID-19 vaccine acceptability in this population. But again, it's difficult to understand what that really means, right? So how is this clinically and contextually relevant? To do that, I think that we need to do more studies, obviously, but mixed methods research, qualitative research, really interview people, long-term survivors, and try to understand how health behaviors change over time. And then we can do quantitative studies accordingly. So I think that because mastery seems to be doing something, seems to be influencing COVID-19 vaccine acceptability in some way, I think additional studies are warranted to examine its role. And if indeed it shows that personal mastery can be manipulated such that people will have higher levels of personal mastery, then interventions can be developed to look at how personal mastery impacts vaccine-related decision-making, right? And determinants of COVID-19 vaccine acceptability and hesitancy is generally understudied in people living with HIV and in diverse samples. And so that is definitely something that future work can focus on. And with that, I will end my presentation and take any questions that you may have.
Terrific. Thank you so much, Dr. Davtyan. That was a huge amount of data, so thank you for getting through that.
No
we
problem.
don't unfortunately have time for questions, but I will encourage people to write any questions in the chat, and Dr. Davtyan can perhaps address those there. And we'll move straight into Jules's presentation with a reminder that we have a hard stop for that at 50 past the hour, so we can wrap up and have any discussion and Q&A then. So it looks like Annie's pulling that up.
That's Jules. Jules is doing
Jules is
that.
pulling it up. Okay.
Yeah.
You wanna go ahead?
So while he does that, I will introduce Jules Levin. Jules is the founder and executive director of NATAP, which is the National AIDS Treatment Advocacy Project. NATAP's website was the first to cover and report online from HIV and hepatitis conference. And today, NATAP is the highest trafficked website in HIV or on HIV and hepatitis, known particularly for its comprehensive real-time scientific reporting. The website, HIV and Aging subsection, contains over 1,000 research studies archived going back 10 years. NATAP pioneered the community HIV and hepatitis treatment education programs in 1996 with in-person community-based symposiums throughout the US every year, and since then holding over 500 symposiums in 25 cities for more than 50,000 participants. And this program has switched to webinars in early 2020, holding 15 webinars with key topics on with physicians and researchers, with up to 800 registrants per webinar, which illustrates its popularity. And Jules started the HIV and Hepatitis C Co-Infection Advocacy and Policy Group in 1998 and initiated the Aging and HIV Policy and Advocacy Group within the NIH 15 years ago. So Jules, go ahead and take it away. Oh, you're muted. Maybe Jeff can.
Okay.
Okay, yeah, there we go. We can hear you.
Okay. You can see my slides, right?
We can see them. They're just not in presentation mode.
Yeah. If you want to
So
click
how
on
do
slideshow.
So if you go to the menu where it says slideshow.
Yeah.
Just to the left. Down a little to the left. It says like transitions, animation, slideshow. Yeah, there we go. Slideshow, and then do play from start. That first option.
Right there.
There we go. Perfect.
So thank you. The title is Aging with HIV in the US and a little bit about New York City. I call it an epidemic. It certainly will become an epidemic. In fact, at the CROI conference we just had, one of the major research presentations was calling this the silver tsunami. And I think that we're going to become overwhelmed with a situation which at this point is affecting a large part of the population, which will soon affect most of the population with HIV in the United States. I'm going to talk about clinical and community care and service needs and unmet needs and research too. Annie talked about NATAP, so I'm not going to spend any time talking about that. But she did mention our symposium series, which we've been doing since 1998. We started it in 1998. We were the first to do this. And we've held 500 symposiums around the country, live in person, and switched to webinars last year. And this is the next upcoming webinar. We bring the leading researchers in HIV and hepatitis to speak to our audiences. We generally, so the last one we had on aging and HIV, Todd Brown from Johns Hopkins spoke 2 weeks ago, and we had 800 registrants for that event. And for this one, so far we have 500 registrants. Priscilla Sue is widely considered probably the leading HIV cardiologist in the field, and she'll be talking about which many consider the biggest problem, heart disease and HIV. This is from the CDC 5 years ago. Look at the top, 2015. Back then, 300,000 people, the bars in red. 300,000 people were over 50. Now those 300,000 people are over 55. Soon they're going to be over 60. It's a big portion of our population over 60. That's a lot of people, many of whom are suffering with increasing numbers of comorbidities and disabilities, physical and mental impairments and disabilities. This is New York City. I'll draw your attention to the bottom where I circled on the right. And you'll see, this was 2 years ago from the DOH. They had listed almost 60% over 50. I think it's a little bit higher. Anecdotally, I'm told that in New York and San Francisco, that right now 70% are over 50. Not quite sure that that's true or it's close to it. But New York City is a very unique place because it has the largest number of people with HIV. And it also has probably the most diverse population than any other city. But San Francisco, New York, Palm Springs, those are cities where the rates of aging are extremely impacted. And Chicago too. I want to raise your attention to the fact that the most affected, impacted people with HIV who are aging who are over 60 and 50, and it varies with age. And there's a big difference between 50 to 60 and then over 60 or over 65. And it really needs to be delineated, that difference. There's a big difference between people who are over 65 and people under 65 but over 50. And this is the study this is the data that came out of HALO, but it's also been replicated coming out of San Francisco and the Compass Clinic, showing the impact on the daily living of independent living activities of people with HIV, and what percentage of people in the older age group are experiencing difficulties in just daily living and getting by. And this study was done several years ago. So the percentages are higher. It gets worse as we move further along in years and as people age. Transportation, housekeeping, taking care of the home, managing your finances. People have trouble cooking and shopping. And, you know, it's not everybody, it's a certain population of people, but it must be recognized that there is a population of people that is really suffering with all these impairments and disabilities. Many of these folks are suffering with aging stigma. So we all know that people with HIV, or a lot of people with HIV, suffer a certain HIV stigma. Well, people who are aging with HIV suffer a much worse stigma, because once they become 65 and they start experiencing or thereabouts more comorbidities, more impairments, more disabilities, they start blaming themselves. They start to feel worse, and their self-stigma starts to really worsen. And many people have very bad experiences around this. And as a result of that and other causes, the substance abuse is increasing in New York and San Diego and other places, I'm sure, for those folks. They're going back to drug use, heroin and speed. These folks have, I would say, the HIV population in general, not everybody, but a lot of people have a lot of trouble navigating the healthcare system. And this is a particular burden in the older population who may not be so healthcare savvy. Education is needed, not just for people with HIV, older people, but the clinicians. And I'm not necessarily singling out any clinicians, but I can tell you in general that the clinicians and the type of care that older people are getting with HIV is suboptimal. In many cases, we're going to use the word that it stinks. And it's very much affected by the insurance reimbursement situation, what's going on. It's 20 minutes in and out in New York City, and a 70-year-old person with 10 comorbidities in New York cannot see their doctor for 10 minutes. And this is just a list of some of the problems that we're facing. And I want to draw your attention to the word homebound. A certain percentage of people, and we don't know because it hasn't been studied and we haven't collected the data, how many people are actually homebound, where they really can't go out and shop and have trouble getting to the doctor and need special care and assistance, and they may or may not be getting it. And how are we going to address the nursing and old age care facilities needs? You know, in the early days, we are back now to where we were 30, 40 years ago for this older population over 65 who are suffering impairments and disabilities. It is back to the beginning again for them. They are where we were 34 years ago. And we're soon going to have tremendous burden and tremendous problem with taking care of these folks, their home health care, nursing facilities, and so forth. In the old days, you remember there were facilities where people went to and died. Well, those facilities are all gone, and there's going to be a big need to have certain facilities to take care of people. We're not talking about that at all. We haven't even really talked about that, generally speaking. We have what I call a failing healthcare system for the elderly population. There's a lack of effective holistic care. The quality of life can be really horrible. And without going through all of this, these are the things that we're all suffering, folks who are over 65. Many of which have been discussed today. Housing is a problem. Polypharmacy was touched on. Some people are taking as many as 16, 20 pills a day. That's unacceptable and extremely difficult to manage. Some people may be taking much less, but many people are taking 16, 20 pills a day. And there's now a concept called de-escalating, where certain people are maybe thought to be should be taking less pills, but we're really not even talking about that much anymore. Many people are suffering PTSD, chemical dependency, anxiety, just because they're aging. and abandonment. Not only do we feel abandoned by the healthcare system, we feel abandoned by the NIH, by the ACTG, by the Division of AIDS, by the NIAID, by the leadership in there, by HHS. We also feel abandoned by, in many cases, by the healthcare system and the doctors and the researchers. Survival. There was a study at Croy showing 9 years reduced survival last year for people with HIV. You can look at the line here in red and the difference between population controls, people without HIV. Yes, okay, it's improved. Yeah, it's still 9 years less probably. For many, it's more. Many people are dying. We just had somebody in the ACTG, a community person, 66, who just died. We don't know how he died. Maybe he committed suicide. Maybe he got a sudden heart attack. It's projected by 2030 that 75% will be over 50. 85% of them will have cardiovascular disease, 30% malignancy, cancers, 23% diabetes. Care costs will increase by 40%. This is never discussed, the care costs associated with elderly and HIV. But this is what's being called the silver tsunami. And a lot of people with HIV don't like that term, and I understand and don't blame them, but it kind of really illustrates what we're headed towards. Unless we get a response by the federal government, which is completely absent. This was the study presented at Croy, where the authors called it a silver tsunami. And I'm not sure if you could see in the right-hand corner for age people over 70, because you could see it, Jeff? Okay, so you see what's gonna happen. 2 comorbidities or more is in red. And for people over 70, it's increasing with time. For people 60 to 70, it's increasing. And for people between 50 and 60, it's also a problem. This is what we're facing in the near future. Okay, I didn't put this in, but here we go, a little razzle dazzle. So, so what's causing all this? Well, we know it's a little bit of a can't-win situation for people with HIV. It is a can't-win situation. You have to be on HAART because you have to keep your viral load undetectable and increase your CD4s as much as possible. That is the best antidote to live and to live healthy and to prevent aging. At the same time, the HIV drugs all have side effects and toxicities and long-term toxicities. And then the legacy effects of people who've been taking these drugs for 30 or 40 years, like D4T and AZT, and the long-term survivors that had low nadir CD4, under 200 when they started their regimen and then became undetectable and increased their CD4s. Low nadir CD4 is a common cause for all the comorbidities. And on the left in yellow are some of the reasons why people are aging, having the problems with comorbidities. HIV and the drugs probably cause mitochondrial damage, aging, telomerase shortening, immunosenescence, a dysregulated immune system. Everyone's heard about inflammation, and then body fat changes. Body fat changes are a big cause. Whether you've had cosmetic surgery or not, the effects of body changes and fat depots are all over your body and persist. This was at Croy showing the differences in orange, HIV positive people, and in gray, HIV negative people, and the differences in the comorbidity burden. 3 or more comorbidities, hypertension, lipids, the increased percentages of people with these problems compared to HIV negative people. This is just the latest study in a series of studies in recent years. I draw your attention to chronic kidney disease, which gets worse as you age. These these comorbidities all get worse as one ages. Heart disease is not here. Frailty is not here. That's coming up. Substance abuse is almost double. Liver disease is triple. Cancer is almost double. Osteoporosis is 50% higher. Draw your attention to neuropsychiatric, much greater in people with HIV. And then on the table on the left, the number of 5 comorbidities or more is double amongst people with HIV compared to people without HIV. And the average age here was 62% over 50. So it doesn't say the average age though, does it? It says 52 is the mean age, but it ranges up to people with 67 years of age.
So Jules, just a 5-minute warning.
Okay.
Thank you.
Why are people suffering aging and comorbidities? Why? Here's an important study from France comparing people over 75 compared to people 50 to 75. And in general, you will see a doubling of the number of percentage with comorbidities for people over 75. That's what we're facing. There's a study from the Netherlands showing the number of comorbidities that one has increases the death rate. So people with 4 comorbidities have double the death rate of people with 3 comorbidities, and so forth and so on. This is a study from California showing the increased costs by comorbidities. And if you look at the bottom, you'll see 11 or more comorbidities, 8 to 10 comorbidities, and the increasing costs based on comorbidities for people with HIV. That's what we're facing. The decline in function and how someone does when they hit 60, 65 can take a very abrupt decline. All you need is one event to take a very swift decline down, which is very hard to recover from when you're over 65. Accelerated aging by 13 years in these studies that have been done with age-associated methylation patterns, accelerated aging. So this is what we can expect. Premature deaths will rise, in my opinion, increased numbers of comorbidities, worse physical and mental function, HIV costs will go up, care for the old infirm will be needed. It's inadequate now. There's an absent federal response. Housing, where are we going to house everybody? We need better care, services, and research for interventions. The NIH and DAIDS is not funding intervention studies for aging people with HIV. Senolytics is the biggest area in aging. There are 39 studies going on right now in HIV negative people, and we have 0 studies in people with HIV, and they refuse to do our studies. They refuse to prioritize aging studies in the NIAID and in DAIDS. They delay our studies. They won't pay for drugs that the ACTG wants to do studies for. And that's part of the problem. I'm not going to spend too much time on this because I'm limited. I want to just go to this. So who's responsible for all this, okay? These are the agencies, and I named some people that hold all the decision-making levers, why we are not getting the funding we want. Everything is PrEP and cure, and aging, we get nothing. It's about politics, and it's HHS, the Office of Infectious Disease, Harold Phillips, DAIDS, Carl Diefenbach, his boss is Tony Fauci. Francis Collins is the head of the NIH. Laura Chiva is the head of HRSA. CDC is Jonathan Merman. They are ignoring us. I guess I might have a minute. I'll just highlight women. This was at Croy. It's been increasing over the past few years, the attention. This was a wise study. I draw your attention first to the panel on the left and look at the dark blue. And you will see as people age from 40 to 50 to 60 to over 70, the amount of dark blue for men and for women increases. And the dark blue means they have 5 or more comorbidities. And you see, as men age into their 60s and 70s, they have 25, 30% have 5 or more comorbidities. But look at women, where it's almost double. Women are much more highly impacted by aging than men. This is just the latest study to show that. Frailty, I draw your attention to the right, over 65 from the MAX, the men's MAX study, 25% of men over 65 have frailty in the MAX study. That's a lot, 25%. This was another study showing 33% of men over 69 in the MAX study had frailty. Fractures and prevalence, I want you to take note that as people age, look on the right, fractures increase for men and for women as people age. The aging phenomena in HIV positive and negatives, osteoporosis gets worse, fracture rates go up, frailty rates go up, and bone mineral density on the left goes down for men and for women, but worse for men. I mean for women. Twice as much for women. And I draw your attention to the panel on the right, where as men and women get over 50, the separation between the positives and the negatives, HIV positive men and women, and how much worse it is for HIV positive individuals over 50. You're seeing the same arc of slopes for heart disease and other comorbidities as well, as you see here with fractures. Highlighting the problem that we face as we age, HIV positive folks. Here it is, myocardial infarction, heart disease. Same thing, I draw your attention to the slope, the arc of increase for men, for people over 55, compared for people with HIV versus HIV negative. And you see the great increase from 55 to 74 for HIV positives versus negatives. Again, highlighting what we're facing.
Jules, we're over time, so if you're able
This will be my last slide.
Okay, thank you.
I could go on. I have probably, but I'll stop with this.
We could go all day, but
Okay, this is cognitive impairment, which this is a good one to stop on. You'll see 45% of people have some degree of cognitive impairment. The problem with cognitive impairment is that people don't want to be called cognitively impaired. They don't understand, many people don't understand what cognitive impairment is. They think that it was like it was in the mid-90s when it was dementia. That stopped with heart. What we've had since then is a low level of cognitive impairment that very often is imperceptible by the person with HIV. That can become increasingly perceptible as they age, but for a subpopulation is perceptible. And a lot of people really, they think maybe that cognitive impairment is some form of dementia. It's not. This is what cognitive impairment includes. Of course, neuropathy is not cognitive impairment, but everything below. Short-term memory, executive function, learning deficit, attention deficit, verbal expression, language facility, mood disorder, emotional disorder, psychomotor speed, processing speed. These all decline. Sometimes people don't perceive it. Sometimes people don't ignore it. But for many people, it's there. And with that, I'll stop.
Terrific. Thank you, Jules, for that great overview. And we knew you'd do a great job of kind of giving us the big picture and a call for action. So I think we've got time for 5 minutes worth of questions and discussions. I know people have been holding those questions since the last couple of presenters. So go ahead and raise your hands. I'll lower mine. and ask away and share discussions. There's been some sidebar discussions in the chat as well that have been useful. So anyone have anything they'd like to share or questions for our last few speakers?
This is Steve. Jules, thank you for that terrific overview. We're clearly at a crisis stage, and I think you've seen it develop, so have I, over 2 or 3 decades. And we're at a point where the indices that you've shown here, things are only going to get worse, not going to get better. As you age, you don't get better in anything that I know of so far, more gray hair. What do we do? How do we change this? Because this is, as far as I'm concerned, a hidden population, an abandoned population. How do we change the course of care for this population?
Yeah, thanks, Steve. And in the chat, Tom and others were talking about, you know, the funding priorities, especially through the NIH. And so a group of us have been meeting through NMAC with the Federal AIDS Policy Partnership, which many of you know has a long history of, you know, doing some great work in terms of lobbying in DC to move the needle on these issues. So we're working with them, and then the plan is to start having a series of meetings with the powers that be, with communities, so they can hear firsthand. They've had listening sessions around the country. Lip service gets paid, and you know the priorities they publish, but it's not really happening. So it's really time for a kind of ACT UP style targeted meetings, doing sign-on letters, not just with people living with HIV, but also clinicians and frontline providers, so they really hear from a broad cross-section. This is, you know, not just a demographic tsunami, as everybody keeps calling it, but you know, it should be a priority as well. Tom, you had a comment?
I just wanted to mention or comment that I agree with the points being made. I think in terms of solution, that even that we as a community would benefit from trying to look at other communities and existing resources to support other communities or other conditions, and trying to see how we might leverage or take advantage or use those resources or lessons learned. I mean, these issues are really important. The issues we've talked about today are very important to us. But the reality is that we're a relatively small population on a national basis. So even though these issues are pressing for us, I don't know that we will be, how successful we will be in getting urgency at a national level, just because of the numbers. And many of the issues we're dealing with are also issues for other communities, for cancer survivors, for just older people in general, but they don't deal with them or deal with them so intensely until much older ages. So we do have some unique needs, but it's also a matter of timing, which is different for us. So how do we manage that? I don't know the answer, but I don't think we're going to get massive new programs or resources in the next 2 to 5 years. I find it hard to imagine that will happen. So how can we use what's already here better? Just a thought.
Yeah, no, certainly that's
and I'd welcome feedback from anybody.
Yeah, and certainly that's an advocacy issue, and there are existing funds with Ryan White, and it's a matter of reallocating those, you know, so that they serve the needs of an older population.
About a decade ago, I shared the stage with Linda Freed, who was the discoverer of the frailty measurements, and she said back then, this was a while ago, that this population, and you're absolutely right, Tom, that this is a smaller population, but they should be a test population for the larger population. So, you know, you go out and do a study on a smaller group, and then you transfer it to the larger. The reality is we live in an aging population, in an aging society. There is no preparation for the larger society at all. I don't see it in the government. I don't see it anywhere. And yes, there are things that we don't know how to do or what to do. but we need to start trying different types of intervention. And maybe the older adult with HIV is that perfect model because of the high rates of comorbidity, a lot of the negative issues and stigma, the isolation that they exhibit. And that might be impactful to extract money and say, okay, here's the test group. We're going to work with them and then transfer that knowledge to the larger society. And geriatricians are the best example. There aren't enough geriatricians today. There are fewer tomorrow. How do we shift that change? And everyone, we all know this, but the government is doing zero about it, zero. So is that ageism or is it enough? I have no idea. But I think it's time for social activism, and otherwise nothing will change. Nothing will change.
Great. Yeah, there's a group out of San Francisco that came up with something they call the San Francisco Principles, based on the Denver Principles of Nothing About Us Without Us, and kind of recasting it for the new era of aging with HIV. So
the other thing is we need celebrities.
yeah,
exactly.
exactly.
You know, that was part and parcel of the early days of the HIV epidemic. They brought the spotlight onto the issue that would not normally have been there.
Well, Steve, we will nominate you to be our poster boy and celebrity.
No.
Terrific. We're at the top of the hour, actually a minute past. So I want to be respectful of everyone's time and turn it over to Annie for wrap up and thank yous.
Thanks, Jeff. And thank you to all our presenters for the great presentations and for the discussions that it generated. It was really great. And Jeff and I think I can speak for Jeff, but we're just so happy that we were able to do this for 3 years in a row. And hopefully we'll be able to do it next year, and maybe in person with a thank you dinner at the end of it, which is the way that we prefer to do it. So since we're at time, we are wrapping up. You may log off if you have to, but Jeff is going to leave the room open. So if you are so inclined, you may stay and we can chat more or just have a social. That is fine too. So we're just going to keep the room open for a little bit. And the recordings will be, I'll communicate via email on how to access the recordings. So thank you everyone so much.
Thank you.
Thank you all for joining. And yeah, if you like, please stay on and we can have some more in-depth discussions about the issues that were raised.